Very much, everyone, and thank you for joining us this afternoon. My name is Regina LaBelle. I am the director of the Addiction and Public Policy Initiative at Georgetown University's O'Neill Institute. And I'm really pleased to be joined here today by four esteemed individuals, policy experts, as well as clinicians, and Shelley Weissman, who is our associate director. I'm going to introduce each of them in turn in just a moment. And they will speak for a bit, and then we'll have some time for questions and answer. So we pulled together this event last week because I think we're all feeling the effects and disruptions in our daily lives from COVID-19. And the public health disparities that exist in our country have become much more apparent to the public in the last few months. And this exists none more so than the addiction policy space. So our speakers today are going to discuss their experiences on the ground, what they're seeing with our nation's substance use disorder treatment and harm reduction services. So we'll talk a bit about some of the recently waived federal rules regarding medication and telehealth. And we'll talk about harm reduction services and recovery support services, all important parts of the continuum of care. And then, as I said, we'll have a moderated discussion that will follow the speakers' presentations. So I want to first introduce Shelley Weissman, who's the Associate Director of the Addiction and Public Policy Initiative and an adjunct professor at Georgetown Law Center. Before joining the Institute, Shelley was the Assistant Secretary for Mental Hygiene in the Office of Governor Andrew Cuomo of New York. Shelley is also a person in long-term recovery. And we're joined, and I'm going to introduce each person in the order in which they'll speak. First, we have Dr. Ingrid Olsen. Dr. Olsen is the Medical Director of the Institutes for Behavior Resources, REACH Health Services in Baltimore City, an outpatient substance use disorder treatment program. Dr. Olsen is also on the Board of Directors of ASAN and co-author of a book published by Oxford Press titled The Opioid Epidemic, What Everyone Needs to Know. She will be followed by Brandon George. Brandon George is the director of Indiana Addiction Issues Coalition, which advocates for addiction through public policy and education. He's also involved in a few chemical jail-based addictions programs in Indiana to help people get the help they need while they're incarcerated. And this program has been replicated in jails all over the state of Indiana. Third, it will be Joe Pritchard. Joe is the CEO of Pinnacle Treatment Centers and is also a person in long-term recovery. Pinnacle Treatment Centers has 134 facilities in 7 states. Joe's chair of the Medication Assisted Treatment Committee at the National Association of Behavioral Health Care. And last but not least is Devin Reeves. Devin is the executive director and co-founder of the Pennsylvania Harm Reduction Coalition. In this position, as well as in his other capacities, he seeks to build constituencies of consequence that lead to meaningful public health policy changes around substance use disorder. And also, Devin is a person in long-term recovery. So thanks again to each of you. And Dr. Olsen, I will begin with you.
Great. Thank you so much, Regina. And it really is a pleasure for me to be among these distinguished colleagues on the panel this afternoon. And thank you all for joining in for this webinar. This certainly is an unprecedented time in our nation's history, at least in living memory. And I think we are all grappling with the anxiety and the uncertainty and clearly the chaos and disruption that it has brought. So I wanted to just take my 5 minutes to really kind of give you a little bit of perspective from what's happening on the ground here in Baltimore City. And I can also talk a little bit about what's been happening based on my conversations with colleagues across the country relative to particularly how patients and individuals with opiate use disorder are managing these days. You know, we had an opioid crisis in the country before COVID, the COVID pandemic, and I think there's been a significant amount of concern that we make sure that we don't worsen that crisis during this time. and that we don't lose sight of the fact that we have vulnerable populations who are either in treatment or need treatment in order to make sure that we can keep going, keep operations going, and make sure that we're getting patients and individuals the services that they need. I'm sure my other panelists will speak to this, but isolation at a time when we're all being strongly recommended, and in some states really orders are to stay at home. Isolating physically is challenging. Isolation is a characteristic of the disease of addiction, and with isolation can come increased anxiety, increased triggers for relapse, even for people who have been stable. And that is certainly an anxiety that we are hearing about from the patients that I take care of here in Baltimore. We are also particularly concerned about the need to be able to continue providing patients with their medications, life-saving medications like methadone and buprenorphine. And we are so thankful for the guidance, the federal guidance, and in our state, also the state guidance that has really made it much easier for us to make sure that patients are able to continue those medications while at the same time practicing the physical distancing that we need in order to reduce the spread of the COVID-19 virus. That hasn't been easy. It has really ended up disrupting much of what we do on a day-to-day basis as an opioid treatment program. We have patients who come in typically Monday through Saturday. Sometimes people come in once a week, twice a month, once a month, in order to really ensure that we are able to help patients practice that social distancing. We have taken advantage of the SAMHSA and DEA guidance that allows for more take-home doses. We've tried very hard to spread patients across the week, the month, so that we are able to, in our waiting rooms, make sure that patients even are able to stand 6 feet apart. We are worried about our staff as well. There is still a requirement that for new patients seeking treatment with methadone, there is still a SAMHSA requirement for an in-person physical examination. In order to do that, we really need the adequate PPE, the personal protective equipment, that is in very short supply across the country. That is a concern that many of my colleagues across the country, across the state of Maryland, where I am, we share. We have tried to get face masks, face shields, gowns. That has been challenging. And so we have been making the most of what we have. We have been trying to be really innovative about having patients come to the back of our building, having nurses try and actually give patients medication at the front door, identifying triage rooms within our building. We have also adopted much of the telehealth guidance that has come out. We serve a population that unfortunately does not have great access to the audio-visual and the visual component. And so being able to actually take advantage of the guidance that has come out both from the federal government and then for our state level regulators, Governor Hogan here in Maryland was probably the first governor in the country that submitted or kind of put out an executive order allowing for Medicaid reimbursement for telephonic only counseling. That has been huge. Many of our patients do not have smartphones that have the ability to even use any type of audiovisual communication methods. And when we have now started calling patients, they are so incredibly grateful for the contact. I think many of them are extremely worried about their own health. We have a patient population that is in Baltimore City and in many places across the country, an older population. Our average age is 50, And many large percentages have underlying health conditions like chronic obstructive lung disease, asthma, diabetes, hypertension, that put them at great risk for more severe COVID illness. And so they are worried. So we have really tried to adopt the CDC guidance as much as possible in terms of kind of the social distancing, using all the regulatory guidance that we've received from SAMHSA and from the DEA, but still really being able to continue operating and providing the services as much as we possibly can to help keep people connected and keep the opioid crisis from getting worse. We don't want to overwhelm emergency departments, hospitals at this time with people who are overdosing or are in withdrawal, for example, unnecessarily. So thanks so much for the time. And I'm going to turn it over to my partner, Brandon George here.
Thank you, Dr. Olson. I appreciate it. And thank you, Georgetown and O'Neill Institute, for putting this together. Some people I really respect on this panel, and I'm here to learn as much as I am to share information. Some of the policy changes that were just mentioned have really been critical to this. I think that how COVID affects people who are drug users and people trying to get into recovery or at different stages of recovery. It's going to depend a lot about your demographic. As Dr. Olson just mentioned, there are some people that are going to be able to take this in stride. They have homes, they have computers, they have the ability to get on these types of webinars pretty simply. There's a huge group of our population that does not have that access. And so they had barriers to getting access when the world was operating normally. And for a large percentage of folks, this has compounded that tremendously. And so people can say, oh, well, we can do telemedicine now. Well, that's great if you have the resources and the equipment to be able to do so. And so while I'm really grateful, Governor Holcomb here in Indiana was with that first wave that Dr. Olson just mentioned of governors who cut policy away to be able to do telehealth. Some of it visual, and what they allowed was any two-way communication that was instant. So as long as it was a phone where you had immediate back and forth, that would be acceptable. Policy-wise, they made it really simple for folks to get reimbursement. Instead of trying to draft new codes or do anything, they just essentially said that any services you were providing in person, you can now do with that two-way communication with the exact same billing codes, the exact same setup. So there wasn't a large amount of training that had to go in place to make it happen. And so I think that we've been able to pivot in some regards pretty quickly there. There's a really large concern about the isolation that was mentioned a little bit earlier. You know, in my area in Indianapolis, there is a little bit over 500 recovery support meetings a week that normally take place, and there's exactly 0 now. And so again, for maybe your average middle income American household, a lot of people are being forced into doing recovery meetings, and they're like, oh, this is great. We should have been doing this for a while, and that's really good. But you know, there's hundreds of people downtown Indianapolis that go to the meeting on the Circle at noon, and they live down there. They live in downtown Indianapolis. They live in camps. They live under bridges, and their way to access recovery is there. And they may or may not have a phone, that may or may not have they can get Wi-Fi on when they go into a public space. But right now, they can't even get into the public spaces because those are closed. So the way that they were able to access internet is no longer available. And so there is still a massive need to outreach to these folks. I'm grateful for our Secretary of our Family and Social Services Administration here and Director of our Division of Mental Health and Addiction. They reached out to the recovery communities and our syringe service programs. So I'm going to let Devin touch on most of this, but I think it's important to acknowledge that we need direct communication from state leadership to our syringe service programs to make sure that we do not have a flood of infectious disease that follows this as well. And so making sure that state leaders are talking to these groups and directly asking. Our director, Jay Chaudhry, just asked me, are all the programs up and running? And do all of them have what they need to keep being able to do so? And we need that type of support, I think, across the board, and not only for that, but to expand. And I'm sure Devin will go into a lot more impact of that. Something else to think about here in Indiana, you know, we a lot of me included, a lot of the advocates have talked for a long time about our hyper focus on opioids, and a lot of us have referred to calling this an overdose crisis or addiction crisis. We've really tried to steer clear of opioid crisis or prescription drug crisis, because we know it's much broader than that. And so I think that's important to take that into consideration during this time as well. That big floods of SOR money that, you know, was relegated to opioids, but with the fact that we have fentanyl that's being cross-contaminated into methamphetamine, there's some ways to make sure that those folks are taken into our system, because they're at risk of overdose as well if they're a stimulant user at this time. Folks with alcohol use disorder in Indiana, alcohol sales have increased 70+%. 70+%. The data I'm hearing from my colleagues around the country is it's 50+ in the majority of states. We talk a lot about medication for opioid use disorder. We need to. It needs to be it's a best practice. It should be talked about widely. But there's also medication for alcohol use disorder. So as we're dusting off the policies, as we're looking at how are we helping these folks, we need to make sure that we've got best practice in place for all of our use disorders across the board. Our governor, Holcomb here, issued an executive order to prevent evictions, which I think is critical during this time. We've got large groups of people that are barely hanging on to their housing and their ability to stay in places. These are also people who are quickest to lose jobs often because they're working hourly jobs and those places are closed down. Unfortunately, 2 weeks ago, I got a call from a resident at a recovery residence, and the owner had given their managers directives this morning to make sure everybody left within 2 weeks. They were going to close the place down. And they were kind of in disbelief, and they said, well, we're thinking about selling the place, so we need to make sure everybody's out of here. And when it came down to it, they were scared that, you know, somebody in the house would get coronavirus and there'd be some liability there. And so I was taken back, as I see a lot of head shaking right now. I had the same feeling, and was really lucky that we've had state leadership, and I would encourage other people to make sure there's lines of communication set up. We were able to talk to the Attorney General's office here, who was able to dust off that executive order, so to speak, and make sure that the owners of the organization were fully aware of the implications of kicking people out during this time. And, you know, we had found places for most of those residents to go, but that was kind of beside the point. The point was that we can't set a standard where these recovery residences can start dumping people onto the streets. So I really think that there's a lot to go here. I want to make sure that when we with the dust settles, we learn from this and we know what helps people and we don't revert all the way back. And I want to hear a little bit more about frontline stuff from Joe Pritchard. And so I want to turn it over to him and see what Pinnacle is doing during this time as well.
Thanks, Brandon. And Dr. Olson, thanks for your comments prior to Brandon and Regina and Shelley. Of course, it's always great to have colleagues and stakeholders that are really trying to create the narrative that we need today during this crisis, as well as when we get through this crisis. Devin's after me, and he'll be a great closer for our initial presentations. I'm privileged and honored to be on this panel. I'm also privileged and honored to be in this field. You know, I represent about 130 programs in 7 states. We treat 30,000 folks every day. And so I think about the fact that 30,000 folks are alive today because of all the great staff that we have and a lot of my colleagues have and are associated with, that get up every single day, put themselves on the line to help another human being. And so I'm just so humbled by the work that we do. And I'm humbled by the association's work. You know, I'm fortunate to be the chair for the MAT committee for NABH. they've been very instrumental in working with ASAM and ATA and other associations to be collectively sending the same message at the federal level as well as down to the states. And I think a lot of things have transpired, have been very fortunate for us. We deal with a highly susceptible population. It's always a delicate balance between medical and clinical integration, the right time. You add a disruptive force like COVID and it knocks everybody for a loop. The tenacity of our program providers is that they will go to any length to provide care. And the federal government has stepped up in many ways to try to help us by really unshackling some with regulations, the ability to do, for example, for opioid use disorder, extended take homes, telehealth, audio, phone, being able to get paid for it. We're getting billing codes now. All those things are fantastic and they're great. There's still some room for improvement. I mean, we should be able to have a physician on the phone with a nurse and a patient in a clinic and do a phone interview, a telehealth interview, and be able to get them inducted. The accessibility to care is of the utmost. Most of our physicians are over 50. A lot of them are highly susceptible and at risk. And it's critical that we get them in front of them in any means that we can. So there are opportunities to do this. Our staff, PPE, we're all struggling with getting the right equipment. All the new testing that's coming out. The reality is rapid tests are great. We're probably third from the bottom of the list of people that are going to get them, quite honestly. And we know that. So we have to struggle with workarounds to achieve what we're trying to accomplish on a daily basis. So these things are very vital. I agree with Brandon and Dr. Olson on some of the facts are that this is an illness, and I call it straight across the board substance use disorder. I don't care if it's opiates or alcohol. It's an isolating disease, and it holds you captive. And when you come into treatment, we wrap ourselves around this individual, and a cadence begins, a recovery cadence. That is disruptive now. We have counselors that are used to seeing their patients in the same room face-to-face that are now talking to them on the phone. We have folks that go to AA and NA and other recovery supports that now are struggling to figure out if they can get Zoom to get to a 12-step meeting. And I know that meeting around the circle in Indianapolis. And those are the things that we need to understand beyond the practitioner, that recovery isn't just an hour a day, it's 24 hours a day. So what we are as being impactful during that time we have with that person needs to follow them when they leave our clinic. So all these tools are fantastic. The last thing I want to share, and I'm going to turn it over to my friend Devin, is that, I worked through 9/11. I worked through Katrina, earthquakes in California, hurricanes, floods, fires. We all get lessons learned from this, but the reality is a lot of times right after the event, the crisis, we go back to the norm. So I'm going to encourage everyone to understand that what will be very important now is that we take what we learn and we start to drive change where it's the most impactful, or we will go back to where we were the day before the crisis came into our lives. So again, I want to thank everyone, and I'm going to turn it over to my colleague and friend, Devin.
All right, there we go. Afternoon, everybody. My name is Devin Reeves. I'm the executive director of the Pennsylvania Harm Reduction Coalition. And, really what I think COVID-19 has done has opened up another layer of people's eyes on how broken our system is. In the drug and alcohol space, in the harm reduction space, we know the problem is the war on drugs, right? We need to end class warfare, race warfare. I mean, I was on Twitter last night and I see that COVID-19 is just destroying a generation of our Black elders. In North Carolina, South Carolina, Chicago, LA, we see that Black people only make up 20 to 30% of the population, yet make up 70% of the deaths. It's the same thing with the war on drugs, right? Black people are disproportionately charged with higher crimes. They're going to jail for longer periods of time. And we must remember that the overdose epidemic only became the overdose epidemic because white middle class America. Oh, can you hear me still? Okay. Yeah. Because people like Brandon started having problems. And, you know, when we think about the crack epidemic of the 1980s, it was more bars, more guards, more prison time. And we must apply that same analysis to what's happening in COVID-19. And just like Joe had said, we need to take this momentum and go forward. I mean, I cannot tell you how many times I heard people at the federal government say we cannot change buprenorphine guidelines, we cannot change methadone guidelines. I know on the state level, we hear a lot of times we can't do that. All of a sudden, during a pandemic where anybody can be affected, how the rules can change. I think it's really interesting how, you know, now that everybody is at risk, we're embracing a lot of harm reduction tactics in response to COVID-19. You know, we're saying, oh my God, public health is important when we mocked and ridiculed public health in the past. And I think the other thing that's the real opportunity now is to push our agenda forward with a COVID angle. So, you know, we're really lucky in Pennsylvania. Our syringe service programs, while designated illegal on the state level, have been designated as a life-saving service. And I think the American Medical Association did a great job saying that syringe service programs, harm reduction programs are life-saving, are vital. They should have PPE. However, that's not happening in my state. We're not on the list for PPE. And, you know, we're working hard as a coalition, but we were able to get extra naloxone, push that out to the most marginalized population. I think everybody should be doing that. I think we should all be doing mail-based naloxone right now because we know so many of the kind of lighter social services are closing, are restricting, and we know that community town halls aren't going on with naloxone. The other big thing that I think that COVID-19 should push the conversation forward in is we need to talk about safe supply. You know, in Canada, they are pushing safe supply conversations forward because they don't know what else to do. And that does seem a far way off to me. However, we should be having those conversations now. We should be having conversations about supervised consumption because it seems like more and more things are on the table. When Andrew Yang spoke about $1,000 a month, you know, freedom dividend for Americans, you know, he mocked and ridiculed him. And then they said, we're going to give $1,200 to every American. Now that turned out to be a loan on a future tax deferment or something like that. But still, socialized programs and socialized thought has really stepped forward to the next level. So I just encourage, you know, if you have the privilege today to have a home, to have a computer, to be able to hearing me, to really step up your advocacy game. You know, get connected with the Pennsylvania Harm Reduction Coalition, the What Your State Name Is Harm Reduction Coalition, or Recovery Advocacy Organization, or your guild or your trade membership, because, you know, 20 years from now, you can say, after COVID-19, I did this to change the way we respond to public health issues. Or you can keep doing whatever weak sauce you've been doing, and things will continue to not change. I'm going to pass it back over to the moderator. Thanks, everybody. Looking forward to the conversation.
Thanks, Devin. I'm going to turn it over to Shelley. One thing that I wanted to mention is that after this virtual roundtable, we will have a website with additional resources, some of which Devin mentioned. We'll certainly link to the Pennsylvania Harm Reduction Coalition, as well as to all the panelists, some of their writings as well. So Shelley, if I could turn it over to you for our moderated discussion. Thanks.
Great. Thank you, everybody. And, you know, so exciting to see how many people have tuned into this conversation. I think, you know, it's a critical time. We're in the midst of 2 public health epidemics. And, you know, wanted to kind of kick off with a few opening questions for the panelists. And then I encourage folks who are participating to type your questions into the Q&A function. And then we'll try to get to as many as possible as we kind of go forward. And I think we're scheduled to go till 1 o'clock today. So get your questions in, and this is, I think, going to be the beginning of many conversations and a bigger conversation we need to have in society. So, kind of first question for the panel, and it's a little bit of a long setup, but obviously the public health response to COVID-19 is having an impact on access to services. Everybody talked about it. Syringe services, treatment, inpatient, outpatient, counseling, recovery support, people getting to meetings, getting access to medication, and the way that people receive those services. And the provider community and harm reduction and folks who are serving people are having to quickly adapt and get innovative, right, to be able to help people get access to what they need. And, so we're seeing this kind of challenge with a decrease in access, and at the same time, this challenge where we have a real increase in the types of conditions that substance use disorders thrive in, right? Social isolation, somebody mentioned that. Stresses related to loss of employment, loss of income, dramatic changes in our lives, the loss of stability or maybe a home, our close family members, our friends, and just the kind of general stress that we're all feeling in society right now. And I think there's been a concern that this could really result in a spike in overdoses, in a spike in problematic use, and wanting to know if you guys are already seeing the impact of this out there in your programs and in your work, and what are some kind of the immediate actions that we can take to address that, to really kind of flatten the second curve. I read that phrase recently, and it really struck me, right? The second curve of the impact of coronavirus on our communities. And I heard people, panelists talking about PPE, talking about communication from state regulators, about things like safe supply and mail-based naloxone. So I kind of want to dig into that a little bit, into some specifics. What right now can folks who are listening and who are working on the front lines in these programs and who are advocating for resources really focus their energies on asking for. And maybe we'll kick it off to Joe to get us started with that conversation. And then
thanks, Shelley. I appreciate that. Great question. And we also have to remember it's self-healing for our staff too. We have a lot of staff. You don't have to be in recovery to be struggling with isolation and all the stresses. So it's very important that we understand that this will continue way beyond the crisis. And we have to readjust as things change for us. So we do a couple things within our programs, and we do everything from residential to sober housing and MAT with all the medications throughout. We constantly have communication with our staff and with our patients. We use patient advocates. We use alumni supports. We have a blog. We have a lot of services that we try to drive to wrap around the patients as well as wrap around our staff. We use our EAP with added services for our staff to be able to have some opportunities. So we try to do that as much as we can. The key for us is going to be, we have to be at the table with the regulators and the decision makers. I'll give you a good example. In New Jersey, rightfully done, they decided to release some of the low offense folks in jail. Most of them are drug related. Would have been good to have a discussion with the providers to say, how do we get them engaged in treatment so they don't walk right out on the street? Those are the things that folks don't understand if you're not in the front lines. We're always reeling from policy that happens that affects us in the way we do things. I think a lot of states are getting us to the table, but those are the things I think that will help us as we go further and deeper into the changes that are needed. So.
Thanks. I just want to make sure to kind of call out one of the things you mentioned, that, the impact on the workforce, vicarious trauma, being supported as we're doing this work, which is, on a good day can be tough work. is something to, really double down on now. So wanted to make sure we call that out. Dr. Olson, did you want to add something?
Yeah, I very much appreciate Joe's. I mean, he's totally right on about really making sure that there is communication between kind of the frontline providers and service providers with regulators. I think the other thing that we have really needed to adapt quickly, as you mentioned, including now connecting and staying connected with patients and with individuals through means that really were not reimbursed in the past or recognized as kind of, relevant or appropriate ways of staying connected. So phone, one of the thoughts that I've had is that, we have a number of patients who they have telephones, but they may have very limited data plans or, minutes on their phones. And so similar to the way that, we have seen governors, like Brandon mentioned, put a halt on evictions. What about actually kind of saying to telephone companies or communication companies that maybe actually not dropping patients or not dropping individuals kind of telephone plans, because they may, in doing that, they may lose the only connection with the outside world that they really have access to if they're sitting at home by themselves. And from a reimbursement perspective, I think we've moved so much of our services to kind of the telephonic or other audiovisual components, but there's much of that in order to continue to sustain services, you do need to get paid for them. And so in states where perhaps that has not been the case, there are programs and providers that are needing to close their doors because they're having to lay off counselors and other types of clinicians because they really can't sustain the lack of visits, reimbursable visits that they're actually now achieving. Peer support services, peer support specialist services. In Maryland, there have been discussions with state Medicaid for a number of years around the reimbursement for peer support specialists within the addiction space. That is not something that has actually come online, but now at a time when peer support and peer support specialists, their services and outreach services can be included and wrapped around patients who may be at home, this I think is another opportunity to really look at, continuing to employ and perhaps even increase the workforce that then can help individuals mitigate the financial losses of lost employment and et cetera.
So to go on to what Dr. Olson was saying there, the repurposing of workers and helping out with workforce issues. In Indiana, we are standing up a full statewide peer network out right now, and not treatment center necessarily, but community-based peer supports, community-based recovery coaches that can operate in the middle of this, our broken siloed system that, as Devin mentioned, is being magnified. And to Joe's point, I think it's really important. Anybody that's worked in reentry knows that it's hard to do reentry when you're planning for it. When you know months ahead of time or years ahead of time when somebody's getting out, we can't do that well. And so flooding a whole bunch of people out is, I want people to be in the community getting better, not in jail because of the lack of access to care, but how do we support them? And so two folks, reentry folks, we're using peer supports for direct communication with our state prisons and then county jails. And then OTPs, there's a real struggle there. We've waived the staffing requirements, so you don't have to have the X amount of nurses and X amount of therapists to keep them open. But there are a few therapists, so they have to be there for intakes, as was mentioned earlier. And so we really need peers to step in and be able to do strength-based groups, life skills groups, and maintain that connection so that the continuity of care or access to care doesn't get shut down because we don't have therapists to do intakes right now, because that's still a policy issue. So I think peers play a big role of letting doctors and clinicians practice to the top of their license, and then peers can help fill in a lot of those gaps.
Thanks, guys. Devin, did you want to add anything, or?
Yeah, sure. One thing that I didn't mention is that there are a lot of kind of organizations that are already in your community, progressive organizations that are doing door knocking, doing things like that. That's another great organization for you to join and be a subject matter expert, because, quote unquote progressives, quote unquote conservatives, all of them are generally very bad at drug policy, just like the general public thinks things like medications for opioid use disorder are replacing one drug for another. You have the ability to be a subject matter expert, not just to politicians, but people that help shape policy. So I just want to encourage everybody to, get in the game. And I know we are all busy, we are all tired, but I want to let you in on a little secret. When you get engaged and things start changing, it's one of the best feelings in the world.
Yes, I can totally agree with that statement. Get in the game, exactly. So really heard some great stuff, and we're going to be kind of compiling all of these recommendations and suggestions as well, and put that up on our website and use it in our own advocacy, and send that around to folks. So I see that there are a lot of questions that have come in on the Q&A. That's going to be our means of folks who are participating asking questions. So I know that the chat is disabled, and I see some people have raised their hands, but we encourage people to put your questions into the Q&A function and use that for questions. So one other question on for folks on the panel. So we talked about how the federal government has started to respond by relaxing certain regulations related to telehealth, related to access to medications like buprenorphine and methadone, and also some emergency funding through the CDC, through SAMHSA, to support states and service providers, grants to small businesses, things like that. And we did just see that ASAM and the National Council came out with an ask. I think it was $38.5 billion with a B, dollars to really support mental health and addiction treatment providers. Is that what's needed? Is more needed related to funding? And are there other specific regulations that are barriers to access that should be waived? Right now there are conversations in Congress about the next wave of support for addressing COVID-19. What else should Congress be doing? And I don't know if there's someone that wants to take that question. Devin.
Yeah, I think that, if we look at some of the other countries and their response, Canada is giving $2,000 a month. Since this crisis started really 3 weeks ago, April 1st is come and gone. People did not pay rent. We have lots of states where people can still be evicted, can be evicted quickly. We know that landlords will come and lock the door. Really what we need is to center the most marginalized population in every solution. People that are experiencing homelessness are being forgotten in the COVID response. We saw in Las Vegas, people sleeping outside on the street, when there are more hotel rooms in Las Vegas than almost any place else in the country. We need to say, how do we make sure that the Black trans woman who's experiencing homelessness can get all of the services she needs the same way a white middle-class man would get what he needed if he had COVID-19. And that may be a leap for this Congress and this administration. However, that's what we need to be saying at the local, state, and national level, is centering marginalized populations. I saw in Boston, there is an outbreak of COVID-19 amongst their homeless population. And even though there's some amazing organizations in Boston that work with, homeless people or people experiencing homelessness, every American city could have that happen. And that's where you need to start, is with homeless people, with marginalized populations. That'd be my first priority.
So I started my career working with the homeless population in Philadelphia. And you're right, Devin, that's the population that you have to think about. Their goal, working in a social setting detox, was, do I go back to being under the bridge tomorrow night. And so there's a lot of things. The governor in California is taking hotels and using them for the homeless population. But more importantly, he's wrapping services around it. We had a call this morning that the residents that are going to work there want to know how they can help drive services that we provide to that population. So there are opportunities. Here's what we run into all the time, I think. People throw a lot of money at us and say, here it is, $30 billion, we want you to do things. I think there needs to be a concerted effort to understand what we're trying to achieve here. And in the middle of this national crisis, what we're trying to achieve is to provide as much care to this population as possible in the safest way possible. So having PPE, having the ability to do remote access with counselors, having our docs being able to call up on the phone and induct somebody on medication, having our residential programs be able to work effectively. Those are all the things that are needed, and we need to drive dollars to support that. If you're bringing new populations in, like reintroducing people back from the jails into a community, or the other issue that we're not talking about is the illicit drug population at this point. Drugs are going down. The ability to get illicit drugs is starting to dry up. So you're going to see an influx of people now into treatment, pain management, office-based practices. A lot of things are going to change as the result of this disruptive force. And that's going to fall on other providers to start to take care of. So dollars should be looked at as how can we take care of the here and now with processes and programs that are necessary. I know Dr. Olson wanted to.
Yeah, no, I would just add that, when you think about kind of COVID-19, I mean, part of the issue is we are trying to balance a multitude of risks. But the biggest risk, particularly when you have widespread community transmission, is that there are people who are asymptomatic but are infected. And so even if we are thinking about, well, we've got, people who are able to isolate at home because they have the resources to be able to do that. When you have populations in areas that are not able to do that, that isn't just their problem. That is all of our problems, because you could then be walking to a place where, there are perhaps homeless individuals who are sitting on the street, and you don't know whether or not they're infected. And so the COVID-19 is, essentially a little bit of an equalizer, in that if we don't pay attention to the needs and how we actually kind of can best meet the needs, whether it's housing and transportation and food and kind of the basic needs for all of us, then we are not actually going to get out of this COVID crisis the way that we need to. So that's kind of number one. Number two, I would say, is that the monies that are needed currently are monies that also, as Joe mentioned, they're monies to help support all of the services that we currently are providing, but in very different ways. In addition, we really have to think about how can we actually restructure some of the services that we are providing to adapt to COVID. So for example, residential treatment facilities. There are a number of residential treatment facilities in the state of New York that ended up closing their doors because they didn't really understand how to handle staff or patients who tested positive. Well, this may now be a time when communities and systems, whether it's at the local jurisdiction level, a county level, a city level, a state level, the federal government level, to really think about how do we actually kind of then take some of the residential treatment facilities that we have and make them COVID-19 integrated medical care, and substance use disorder care, mental health care, and so that we're really able to actually take care of people, and perhaps have a COVID hospital kind of that also is able to actually start people on medication. for their opiate use disorder or treat their alcohol use disorder. We have lived in a segregated, a siloed, as Devin mentioned, kind of very siloed, fractured system for a long time. We can't do that now because we are all going to feel the impacts of whether it's, the addiction crisis, or whether it's really now at this point, the COVID crisis. So we do have to be innovative and kind of think beyond the box.
So thanks, guys. So we've got a ton of questions coming in, and obviously not time to get into the answers to all of them. So I'm going to try to group some of them together. We have a set of questions that are about kind of the specifics of practice on the micro level, how to help folks right now. And then we have a set of questions that are more kind of policy focused. So I'm just going to start with the kind of practice questions and kind of throw out a couple that I think are good, examples of some of the types of questions we're getting. So Carly from South Florida is asking, do you all have any suggestions on how we can be helpful right now to our clients on a micro level? It's hard to get clients into treatment. Somebody asked about making sure that people have access to a phone, and I think that's, what are the requirements for access to, an Obama phone that somebody called it. And I think, that's an example of the many kind of case management functions and resources that are out there that people might not really even know about, that are kind of access to services and resources that help support people's recovery. How do we communicate with patients who might have their, like you mentioned, Dr. Olson, some programs that maybe have closed their doors for now? Those patients do. So kind of questions like that. What are kind of best practices right now for folks that are direct on the front lines right now?
Can I just, 2 minutes, because we're dealing with this across the country in many different environments. And so we have a COVID task force internally of the executive leadership team, and we meet twice a day. And we have people identified to do very specific things, from PPE management to compliance. And I do a town hall for all employees every week. And there's an email and an 800 number. We have that for the patients too. I think it's important to know that what you have to do at a facility level is different than what you do at a corporate level. You're on the ground, you know your community. You need to task 1 or 2 people to have those connections in the community with those associations, with those other stakeholders, homeless shelters, care workers, healthcare providers, and you have to case manage. The OTP side, you have a lot of case management that goes, but not so much in the traditional sense. You have to take more of a traditional behavioral health case management, community resource direction with this, where you have to connect the dots between that patient and the services. In Pennsylvania, where Devin is, and I'm privileged to do work, they have Center of Excellence. Governor Wolf introduced dollars to support linking people where they need services, not just for addiction, but all the other services. So I think that's one of the things that you have to do. We've contacted other quote competitor providers, and we have a weekly meeting to talk about how do we support each other. If somebody ends up having to close down or quarantine, how do we provide support? How do we give you PPE? How do we take care of your patients? Those are the things that you can actively do to take it away from what you're doing and what you need to be doing for the patient.
I just wanted to, I think that's great advice. I also just wanted to add that as providers, if there are provider associations in your state, to really reach out to your Medicaid, your Behavioral Health Administration, to your state opioid treatment authority, if that is kind of relevant to you, and ask for weekly meetings, weekly phone calls, essentially kind of taking a little bit of an incident command structure type joint operations team model, and really kind of trying to implement that, because the folks at the state, they are also very interested in trying to understand what is happening on the ground. How is it, what are the needs on the ground? Not that they can necessarily answer all those questions immediately, but it is something that a two-way communication stream can be really helpful. The second thing I just wanted to add briefly is that, so for frontline providers of addiction treatment services, ASAM has developed a task force that they stood up, I chair, that we stood up about 2 weeks ago, that has rapidly developed some practical clinical guidance for various different treatment settings. So outpatient, residential. We are putting out an OTP, opioid treatment program guidance, by the end of this week. Other types of, access to buprenorphine and OBOT models. So if folks go and Google ASAM COVID-19, they will get to a web page that has a whole host of these different guidances, including a very thorough, very well organized list of all the national federal regulation guidance that has come out, as well as some of the state compilations. And ASAM is really working to try and get information through various different systems, through its chapters, its councils, its regional directors, from the ground and up, because we absolutely know that there are folks out there who we've all had to be creative and kind of figure out how to manage all of this in a very short period of time.
So thank you guys. So we've got, about 5 minutes left, and I think, we've got some great questions that came in, and I think what we'll do is go through them and try to kind of organize some kind of a Q&A in collaboration with some of the provider trade organizations and advocacy groups that are part of this conversation. And just to kind of chunk a set of questions together, and also as final thoughts. Devin, you mentioned getting involved. There are a lot of people who are listening in right now, both that might be new to these systems, who are just getting involved, or who are people in recovery, or people with lived experience, or people who have been at this a long time and, just are seeing this public health crisis as a place where it's just magnifying issues that we've all known have been their own plague on our systems, right, for as long as we can all remember, and everybody in between. And, to kind of close out, I wanted to ask each of you, what would be your call to action for the folks that are listening? Whether it's about policies that should be set in place, or, a new way of thinking about the system, or is it about the one-on-one kind of interactions with people that come to us for services, or with each other. So, or anything else that you wanted to kind of close out with. So why don't I start with Brandon, and just, 1 minute for each of you guys, since we're coming close. This was a fast hour.
Absolutely. And so one of the things policy-wise, we've directed a lot of funding through traditional channels. And our most marginalized population doesn't touch those channels. They touch our harm reduction coalitions. They touch our recovery community organizations. My jacket might as well be privilege over here. I wake up one day and I don't have to make my house payment anymore. Well, I guarantee you the landlord that Devin was talking about is still going to collect rent from the person there. My student loans are suspended now. And so I'm grateful for that, but the folks that need it the most aren't getting that relief. And so as we set policy to get $38 billion out, I think there needs to be a heavy reliance on recovery organizations and harm reduction coalitions to get it to people who need it the most.
Great. Devin?
Yeah, so real quick, check us out on social media at PA Harm Reduction, at Devin Reeves. We have an upcoming advocacy training. It's supposed to be for people in Pennsylvania, but anybody can come and learn how to up your advocacy game. You may have a local organization that does it, but it's online, it's free. Come check it out. Learn how to make a change and then start making a change. Thanks, everybody. I appreciate the opportunity.
Joe? Oh, you're on mute, Joe. There you go.
Okay. The important thing for everyone, I think, will be looking at what's happening right now, what's in front of you. How do we take care of patients and staff effectively and safely? And where can you get the resources necessary to do that? Not just in the clinic, but beyond. Recovery supports, as Brandon and Devin have mentioned, working at the local and the state level to be at the table to say, these are the things that we need today here in this state, here in this community, to do the things that we need to do to treat patients and to take care of our staff. We should then, in addition to that, begin to start to evaluate what is working, what is impactful, and what's not working. So when we're through this, we can have an intelligent discussion around how to make what we do more impactful tomorrow. So.
Great. Dr. Olson?
So thank you to everyone for allowing me to be part of this. It has been really a great discussion. I would just add that evaluating and not forgetting that we actually do need to still be watchful for the addiction crisis. We were, measuring overdose rates every day prior to this. We need to still be actually kind of keeping an eye on that in a very qualitative and quantitative way, so that we can actually do what Joe mentions, which is then learn from what has worked and what hasn't. And I would say that, this is a time when we all Americans really need to be thinking not just of themselves and their families and their communities, but all of us together, because we are in this together and we are going to need to get out of this together.
Great. Thank you, everybody, so much. I'm going to turn it back over to Regina for final thoughts.
Thanks very much, everyone, all of our speakers, everyone who listened in. We will have information, as Shelley said, we'll send this out, send some Q&As out. We'll have a resource paper or website for folks to refer to. And this has been recorded, and we'll also provide this as well. But obviously an hour is probably not long enough to have the robust discussion, but I think it's been really helpful. And we will be following up with additional virtual roundtables of this sort. And also look for more information about a new master's program that's been approved at Georgetown, a master's in addiction policy and practice that will kick off later on this year. We'll have more information about that for kind of, as Devin said, allowing people to get involved in this issue and understand from a clinical basis as well as a policy basis what it really takes to make a difference. So thank you very much. Stay safe and have a good day.